So welcome everyone. Uh, so this is actually a thing which I have been thinking that I should be doing because dengue is one of the most important areas where especially ERPM students are tested on, because number one, dengue is more endemic to Sri Lanka and the Southeast Asian countries. Another thing is that usually dengue patients monitoring, critical decision making are mostly done by the house officers in most of the places. There can be places where there are registrars, there can be other postgraduate trainees, but most of the time it is the HO who detects the patient is deteriorating. So they expect us to have a good knowledge on how to detect a deteriorating patient, right? So the exam, I think this session's exam is in 2 days, 25th. So I just wanted to uh, brief you through the guideline with some cases so that you don't have to be memorizing things. Now, just let me know if you can see the screen. Right. So, how do you see the screen? Do you see it like a full screen slideshow, or do you see it like a presenter view? I'm just curious. How do you see it?
Present, like we can see the main page and then the next slide, no notes.
Right. So that is the page you see. Wait, let me change that. Okay. Now do you see it in full screen?
Yes.
You see it in full screen, right? Right. Okay.
Yes.
Great. So, so all about dengue. I mean, that is a complete misunderstanding. I can't cover all about dengue in one session, but I can cover what you need to know as a house officer and what we expect you to know when you come to internship, right? So this basically all of these I have taken from the dengue national guidelines, so you don't have to find anywhere. You can download it free from the National Epidemiological Unit official website, right? All the dengue guideline, lepto guideline, right? So what we need to know is that now you see me annotating, right? You see the annotations on the screen, the pen moving, me writing, right? Okay. So most of the time, what we would be dealing is with this, the undifferentiated fever. Uh, Most of y'all would have got dengue, but it would have been just a viral flu where you get fever, body aches, and then after 4 or 5 days you feel better. Now, let's say if you have around 100 people, out of that 100 people, around 70% will be in this spectrum of undifferentiated fever. Right? That 30% of people are the ones whom will definitely follow the course of dengue fever. Now, out of that 30%, only 50% will show signs of leak, plasma leakage, which we call as dengue hemorrhagic fever, right? And this one is extremely rare, where you have other organ manifestations like dengue liver failure, dengue encephalitis, dengue myocarditis, right? It's very rare. So far, I have seen only one dengue myocarditis and one dengue encephalitis. It's that rare, right? So now, what I was wanting to tell you is that dengue viral infection most of the time is asymptomatic, where you wouldn't even notice. Now, the symptomatic ones can come in various presentations. It could be in an undifferentiated viral fever, where you wouldn't be able to differentiate from other infections unless you do a NS1 antigen. Right? Next is dengue fever. Now, dengue fever, the spectrum has two components. They can come with bleeding manifestations or without bleeding manifestations. The main pathogenesis is because there is a platelet dysfunction. There is a platelet dysfunction. Now that is called thrombasthenia. So platelet dysfunction. So most of the dengue fevers don't bleed, but sometimes they can come with bleeding. Now when they go into plasma leakage, they can present without shock or with shock. Now we should not forget that the name itself tells you dengue hemorrhagic fever, because before 2009. Now, 2009 was a period where Sri Lanka was having a very bad dengue epidemic, where many patients were dying, many pregnant mothers were dying. We were not having the proper experience in how to deal with dengue. So what happened is, a set of consultants, a set of physicians and pediatricians from Thailand had come to Sri Lanka to help us understand the pathogenesis of this disease, because they have been dealing with dengue a lot more than what we've been dealing with. Right? So this national guideline was developed solely based on the experience of the experts from Thailand. Right? So before 2009, the practice of treating dengue was completely different. There were people who used steroids, there were people who used inotropes when patient went into shock, and there were instances where we had transfused platelets to patients who had thrombocytopenia. Right? So after 2009, we understood actually what is the disease cause. So we should not forget that the name itself says dengue hemorrhagic fever, so we should be worried about hemorrhage. But before 2009, we were well thought about hemorrhage, but we never focused on leaking. Now, the concept which was new to us in 2009 is leaking. Now, that is the thing which we built our guideline on: safe fluid prescription and making sure that your vital organs are perfused, right? But now the trend is that we all are so engrossed at leaking, we tend to ignore bleeding. Now, that is one emerging problem. There can be occult bleeding in dengue where you will miss. They might go into refractory shock even though you give fluids. So that is one thing which I want to highlight today. Right? Okay. So febrile phase. Now we know dengue fever has a febrile phase and a recovery phase. So dengue fever has a febrile phase and a recovery phase. Now, if it is DHF, dengue hemorrhagic fever, they have a febrile phase, a critical phase, and then a recovery phase. Now, what do you mean by critical phase is that is the time period. That 48 hours of time period is where your vascular permeability is so high that you have a plasma leakage outside. Now, this plasma leakage is the main problem causing agent in dengue, because it depletes your intravascular compartment, leading to vital organ hypoperfusion, leading into multi-organ dysfunction syndrome. So dengue is quite dangerous if you don't monitor, if you do not support the leak, right? So that is what we have to understand. So febrile phase usually lasts from 1 to 3 days. This is in the majority. But in some people, there can be a extended febrile phase. There can be an extended febrile phase until around 5 to 7 days. So sometimes patients with dengue can have prolonged fever spikes even until 5 to 7 days. So Yes, we have to think about other differential diagnoses while in the ward, but we should not forget that sometimes dengue febrile phase can have an extended febrile phase. Okay. So what are the symptoms they could come with? They will come with classical headache. They will come with retroorbital pain. They will come with myalgias. They will come with arthralgias, right? They would come with loss of appetite, which is very significant, right? These are the features what they would have in febrile phase. Most importantly, fever, which is responding to paracetamol, but recurring every 6 hours. Now, that is the classical fever what we see in dengue, right? So during this period, what is the complications we can expect during febrile phase? One thing is dehydration. Dehydration is the most important complication in febrile phase. Next is the bleeding. Even before the critical phase begins, in febrile phase itself, platelet dysfunction will start. So you can start bleeding. This bleeding can be obvious bleeding, and it can also be occult bleeding. The most common obvious bleeding is your menses in females. Now, usually when you get a girl, a female patient, they would not highlight on their menses. Usually they would be having a regular flow, but in dengue the flow would be high. But it is very rare that a girl would think that this is abnormal, so they would not open up. So always when a patient is on menses, you need to ask, what is the flow like? So to make sure that is this the reason to have obvious bleeding. The next is the occult bleeding. This is only detected by serial measurements of your HCT, or what we call PCV, okay, packed cell volume or hematocrit. So without this, you wouldn't identify, because if the patient is having an upper GI bleeding, the melena would start to present after 24 to 48 hours. By that time, it is too late. But hemo concentration hemo concentration would be first in occult bleeding. So that is what we need to make sure we have to sort out. So how do you manage febrile phase? What do you have to avoid in febrile phase? The most important thing is avoid NSAIDs. Avoid NSAIDs, because most of the time for body aches, for muscle aches, they have a tendency to take diclofenac sodium, ibuprofen, ketoprofen. No, NSAIDs can cause bleeding, so we don't advise them. Next is people who are on single antiplatelet therapy or dual antiplatelet therapy. In during febrile phase, it is best if you can withhold for that period, because you have a platelet dysfunction, they can promote bleeding, right? So single antiplatelets and dual antiplatelets during the febrile phase, we keep them stopped. Next is steroids. Now, people have a practice that when they have a viral infection, they normally sort for these general practitioners out on every nook and corner. They prescribe you steroids, dexamethasone or methylprednisolone or prednisolone. Now, what happens is you feel better because it blunts your immune response and you feel better. Fever stops immediately, and patients are also very happy and very satisfied that this doctor gave me just 4 pills. I took the 4 pills, and the next day, bam, the fever is gone. But the problem is steroids will alter the course of dengue, where you will not have the typical drop of WBC, which you will see in full blood counts. Steroids will cause a leukocytosis, which will make you misinterpret it as a bacterial infection, right? Then what happens is suddenly when they pass the febrile phase and go into leaking without noticing, without monitoring, they go into shock. and that is the problem, because they go unnoticed because they are on steroids. So steroids very bad option if you're having dengue. Always when you're having fever, unless until you have excluded that you are not having dengue, do not start steroids to anyone, right? Okay, so that is regarding the febrile phase. What do you need to know about febrile phase? Critical phase. Now, just remember that critical phase is always 48 hours. It is a very clear-cut pathophysiology. Now, we know that if you take y-axis as the amount of leak and the x-axis as the time, and this is the amount of leak. Usually, this is 0 and this is 48 hours. So, this is 24 hours. So, the leak is usually like this. So it follows a bell-shaped curve, a normal distribution where initially the leak starts slow and gradually increases, peaks out at 24 hours. The leak will become maximum at 24 hours, where this is the place where most of the complications do occur. So always take a note that when you are having patients with dengue who are in critical phase, you should make sure that you are very cautious during the 24-hour period, because that is the period where they will develop complications, right? The next point I want to tell you is that not everyone will follow the same trend. This is the normal trend now. There are outliers. There are people who are slow leakers. There are people who are rapid leakers. Now, how would a slow leaker look like? The leak would be so slow and then peak, right? So now what will happen? These people develop complications during this period, during the latter period, right? Now, what would happen in a slow, sorry, this is in a slow leaker, sorry, not a rapid leaker. In a slow leaker, what will happen is they develop complications towards the latter period of critical phase. What about a rapid leaker? A rapid leaker would be like this. They would develop complications in the early parts of the critical phase. So, what do you get by this is that you don't know what is your patient. Is your patient a slow leaker, fast leaker, or a normal leaker? So this will be evident as a retrospective analysis. After the patient is done with leaking, then you will know how did he leak. Now, according to the leak, your fluid prescription, let's say we are following the normal fluids, so your fluids also should be like this, increase towards the peak and then reduce towards the both ends. So your fluid prescription should be based on how the patient leaks. Now that is what we are trying to teach and train you all to, how to gauge the fluids in dengue. That is the most important thing. Now critical phase, what would the patient feel? The most important thing is fever free, the period of defervescence, period where fever is over. The moment the fever is over, the patient will feel well for few hours, then that is when the leaking starts. Now, once the leaking starts, as long as you detect the leaking and you give proper fluids, you won't have any issue. If you don't detect the leak, if you don't detect the leak now, that is where you have the problem, because you are not giving enough fluids, you are not matching the leak, you are going into an intravascular compartment compromise that would lead to organ dysfunctions, right? So fever free. Now there are some signs where I would tell in the later course of this presentation, there are some signs of critical phase, where how would you detect a person going into critical phase, right? So what are the most common complications of critical phase? Now critical phase is they can go into shock. Now the shock can be due to leaking. it could be due to bleeding. Now we need to make sure we judge properly. Is this shock due to a leak or is this shock due to a bleed? If there is bleeding, you need to give blood transfusions. If there is leaking, you need to give fluids or colloids. So that is very important. Now that also I will be teaching you during this course. So shock is the most common complication of critical phase. So we know in febrile phase, the most common complication is dehydration and bleeding. In critical phase, it is shock, and this shock could be due to leaking or due to bleeding. Next, after the shock is over, sorry, after the critical phase is over, then you come to the recovery phase. Then what happens? All the fluid which has leaked out to the extravascular space will be reabsorbed back into the intravascular space. Now what happens? Now let's say you have leaked 1000 ml out to the extravascular space. During the recovery, all this 1000 will come back to the vascular space. Now, if you had given 1000 ml as IV or oral to match the leak, during this leaking phase, you would still have this 1000 ml in your intravascular compartment where you will eventually pass it in urine. And during the recovery phase, when this comes back in, this will gradually pass out from your urine and you won't have an issue. Now, the problem is if you give too much, then what happens? If you give too much of fluids, the time when you are in recovery, what happens is there will be a fluid overload. Fluid overload. Now, this is the most common complication in recovery phase. Fluid overload. Because over enthusiastic fluid being given during the critical phase would lead to a fluid overload in your recovery phase. That will lead to generalized edema, to pulmonary edema and heart failure, right? So that is a very unpleasant situation where you have been managing the patient very well, and finally during the recovery phase you see the patient dyspneic, all swollen, puffy. You will have to put him on a CPAP and Lasix infusion, right? All sorts of things. So fluid overload is a point which you have to consider. Now during recovery phase, what is the most important thing? Patient will be feeling well. There will be something called the convalescent rash. Now, how do you describe the convalescent rash? It is actually a red sea with white islands. Means the skin will be so erythematous where you will see patches of normal skin. Now, that is what I mean by white islands. The skin will be completely erythematous where you will see patches of normal skin. Now they will have an itch. Now important thing is that the itch will be only in the palms and soles. Mind it that the whole body will not itch. If the whole body is itching, that there might be something else going on. The itch is mostly on the palms and soles, but you will see the rash on the trunk, arms, abdomen, right? Now fluid overload can happen due to one thing which I have been telling you, over enthusiastic fluid prescription. The next thing is wrong timing of your critical phase. Let's say you have to start your critical phase at 10 a.m., but you missed it. You started it at 4 p.m. So how many hours? 4, 5, 6, almost. There is a 6-hour delay, right? There is a 6-hour delay in starting the critical phase. So what happens is you tend to not give enough fluids when you need to give fluids. When the patient is really in the peak of the leak, you are not matching the leak with fluids. Finally, when he is going into recovery, when he is going in the descending arm of the critical phase, now you are overloading him. So that is also a reason why a patient can become overloaded during the recovery phase. So one thing is over enthusiastic fluids. One thing is that you are the timing is wrong. You are not giving fluids when the patient needs the fluid most. So that also I'll teach you, because that comes with experience. So that is why the most experienced person in the unit should decide and correct the timing of critical phase, right? Right. So what does this, let's talk about this case. So there is a 32-year-old previously healthy girl who comes to the OPD with a headache, arthralgia, myalgia, and fever for 3 days. Now, she has a erythematous rash over her face and trunk. WBC is 3800. Platelets are 142. So the normal amount of platelet is from 150 to 350. Right? So the platelets are slightly reduced. Now she does complain on vomiting, abdominal pain, gum bleeding while brushing her teeth. How would you manage this patient? So now the patient is having a febrile illness for 3 days, and she has the typical symptoms of dengue like headache, arthralgia, myalgia, and this erythematous rash. The patient is basically flushed. The patient is so red, like he, she would look like a tomato, right? So the patient is flushed. Now, during this time, the patient brings you a full blood count with a leukopenia and a thrombocytopenia. So unless you exclude that this is dengue, any febrile illness with a leukopenia, thrombocytopenia is considered dengue in Sri Lanka. Now, how would you manage this patient, right? So you are seeing this patient. So will you admit this patient or not? First thing is to decide whether to admit or not. Whether to admit or not. Now, next is, if you are not admitting, what do you do for home care? If you are admitting, what do you do for ward care? Now, under home care or ward care, you have to prescribe this patient fluids. So basically, you tell the patient to avoid all red colored fluids, because in case they do develop bleeding and develop melena or hematemesis, if they have taken something red, we won't be able to distinguish whether is this redness due to bleeding or due to something she or he has eaten, right? So we advise them to get clear stuff. Next, what do? You tell them to take a 50 ml per kg, 50 ml per kg for 24 hours. Now, this is your maintenance. So, for a person who is 50 kilograms, for a person who is 50 kilograms, it is 2500 ml over 24 hours. So basically, roughly, we tell them to drink around 120 or nearly 100 cc per hour, 100 cc per hour of water. So more than water, what is best is either ORS or Tambili. They are the best because they have electrolytes. Next, what do? You have to make sure you do full blood counts daily. You have to make sure that you do full blood counts daily, so that you monitor whether the platelets are coming down rapidly, or are they getting into a critical phase, or are they just going into recovery. Now, there are some things which you have to advise the patient that if you get these things, come back to the hospital and get admitted. Now, they are called alarm signs. What do you mean alarm signs? We need to make sure we advise the patient what are the alarm signs. What does that mean? That means they are the signs which tells you that you are going into the critical phase. right? So they would have right hypochondral pain. Why they are having a right hypochondral pain? Because of the leak, the first organ to be affected is your liver. So that pain is because of a liver going into ischemia. Liver, a hypoxic liver that causes right hypochondral pain. Next, you can have features of gut ischemia. Features of gut ischemia. This can be epigastric pain, this can be dyspeptic symptoms, this can be loose stools, this can be vomiting. This can be epigastric pain, loose stools, nausea, vomiting, and epigastric pain. So gut ischemia. Gut ischemia is the next what you have to advise them on. Next warning sign is if you have postural dizziness. Postural dizziness. Now, what do you mean by postural dizziness? Like when you are seated, you are fine. The moment you stand up, you feel lightheaded. You feel like you're gonna fall. That shows that normally when we stand up, there is an element of gravitational pooling of your blood. Now, if your intravascular compartment is filled with fluid, this gravitational uh, this gravitational pooling will not affect you. But when you are having an intravascular compromise, what happens is that you can't maintain your diastolic blood pressure properly. So that causes a postural drop. That causes a postural drop. Postural dizziness is very important in terms of detecting critical phase. So right hypochondral pain, features of gut ischemia, postural dizziness, right? These are the warning signs. And then next is overt bleeding. Let's say the patient is having menses or the patient is having some melena, overt bleeding, you need to get admitted, right? Right. So this is the rough idea what you need to do. So this patient here, this patient does complain on vomiting, abdominal pain, and gum bleeding. So what would you do as an OPD doctor? You would admit this patient. Now, normally the cutoff for admitting the patient is platelets 130,000, but this is 142,000. But still, there are warning signs. If there are warning signs, you admit the patient. If they did not have these warning signs, you can prescribe the proper fluids, give the proper advices, and tell the patient to come tomorrow with a full blood count to review. That could be the option where you can manage this patient as an outpatient. But since this patient has warning signs, you need to admit, right? How would you monitor this patient in ward? Okay, how would you monitor this patient in ward? Now, this is dengue fever febrile phase. In febrile phase, we need to monitor using something called the blue chart. Okay, I'll show you what is a blue chart. Only thing is that the chart which I have is not blue because it is printed on blue ink. Okay, unfortunately, I have it in black, but imagine that it is a blue chart. So blue chart is a chart where you monitor vitals 3 hourly. The aim for this monitoring is to detect patient leaking, right? Now this is the chart I'm talking about. This is the chart I'm talking about. So here you write the patient's name, Miss X, age 18, BHT number, ward number, and then the date and time of admission. Most important, look here, most important is the weight. It is very important to fill the weight because according to the weight only you prescribe the fluids. Now look at this, right? Look at this. indications to call for immediate advice. Now, this is mentioned in your guideline. So that means this is a circular that these things, if they are not adhered, if something goes wrong, you can be questioned on, because these are mentioned in the circular. So a pulse rate more than 120 with fever, or more than 100 without fever, because when a patient is having fever, due to the fever they can have a tachycardia, but an inappropriate tachycardia is something to worry about. Now fever per se will have a tachycardia, but if there's a tachycardia which can't be explained by this fever, now that can be due to a leakage. Next, pulse pressure 25 to 20 or less in supine position. Now, if the pulse pressure starts to become narrow, you don't wait until it goes to 20. When it goes to 20, it is called a compensated shock. So before that, you need to detect. If the pulse pressures are starting to become narrow, like 25, you need to be alert, because it could be due to leaking. Next is the postural drop. So how do you check the postural drop? First, you check the blood pressure while the patient is supine flat. Then what do you do? If the patient is on the bed, you tell the patient to be seated and make sure they put the legs down. If they keep the legs on the bed, that won't be an appropriate postural drop, postural element. So you need to make them put their legs down. Don't make them stand. They might fall, knock their head, and that will be a big mess, right? So keep them on their bed, just put their legs down, that will be enough. So here, a postural drop of more than 20 millimeter mercury, very significant, that could be due to bleeding. If there is significant bleeding like hematemesis, melena, bleeding PV, that also could be due to a DHF manifestation. If the urine output is reducing, normally the gauge of urine output is 0.5 ml per kg per hour. If the urine output is less than that, you need to make sure that is this due to leaking or not. Next is the capillary refilling time. Very easy thing what you can do in every bedside moment while you're talking to the patient, while you're doing the ward rounds, you can just check the capillary refilling time. So your pulse, so your pulse rate, pulse pressure, postural drop, if there are bleeding manifestations, the urine output, and then finally the CRFT, right? Okay. So here you meant like write the date and the time, and you see the pulse rate, you see the blood pressure on supine, you then document the pulse pressure, okay, and then you have the CRFT, you have the respiratory rate, and then you measure, you document the hematocrit. So in this blue chart, you monitor vitals 3 hourly, you monitor hematocrit 6 hourly, you monitor urine output 6 hourly, monitor vitals 3 hourly, hematocrit 6 hourly, urine output 6 hourly. Right? Platelets like full blood count once daily is enough. Right? So just when you are going through this chart, now when you're going through this chart, like let's say here it's less than 2, less than 2, less than 2, less than 2, then now it's 2, then it's 3, 3, 3, 4, 4. So now you see somewhere here the patient is having a problem. Likewise, in the pulse pressure also, it might be 30, 32, 34, then 30, then 26, 25, 20, 18. Okay, now here there is a start to drop. So when looking at this chart, you can identify where is he leaking. So at what time is he starting to leak, right? So that is why this blue chart is very important, that it will help us to detect where and when the patient is leaking. Now, these are the warning signs I used to tell. Now, with a platelet count of less than 100,000, but now they have changed. Now it is 130,000. When there is less than 130,000, we admit the patient, because we now their main idea is that they want to make sure that they don't miss anyone going into leak at home. So we don't wait until they go into 100,000. When by the time they come to 130,000, we admit. Now by day 3 of fever, if they have abdominal pain or tenderness, persistent vomiting, like pleural effusions, ascites, mucosal bleeding, lethargy, restlessness, liver enlargement, that is due to hepatitis of dengue, or it could be due to the inflammation of an immune response. Next is increase in hematocrit. Now, when the patient is leaking, your hematocrit will gradually start to rise, because gradually your blood is being concentrated. So your hematocrit also will gradually rise. If your hematocrit rise is more or equal to 20% of baseline, this is suggestive of leaking. If your hematocrit rise is more or equal to 20% of your baseline, it is suggestive of a leak. If the hematocrit rise is more or equal to 30% of baseline, be very worried, because this is compensated shock. This is compensated shock, right? So these are the warning signs what you have to look at for admitting patients during the febrile phase. Now, there are some instances where when certain patients, even if they don't have warning signs, you still have to admit the patients, like pregnant mothers, elderly patients, obese patients, patients with other comorbidities like diabetes, CKD, ischemic heart disease, blood disorders like thalassemia, sickle cell disease, and then people who have social issues, like people who are living alone, who don't have proper social support, who are dependent on their activities of daily living. So these patients, the even if they don't have warning signs, admit them, right? So how to manage dengue fever febrile phase at home? We discussed. One thing is avoid NSAIDs and steroids. Next, 100 cc per hour fluids, or more precise is 50 ml per kg in 24 hours. The best fluid is either ORS or king coconut, right? Avoid red colored foods or liquids, okay? And then full blood count once daily, and review the next day. Review the next day. Paracetamol 15 milligrams per kg, you can take 6 hourly, but the ideal thing is whenever you have fever, whenever you have fever, so 15 milligrams per kg, right? So we tell the patient to come back to the OPD the next day so that we review them. But if they have these things, we don't tell them to wait until the next day, we tell them to immediately come to the hospital. If there is clinical deterioration with settling of fever, clinical deterioration shows that they are leaking. Inability to tolerate oral fluids, that means they are vomiting. They are having features of gut ischemia. That is why. So they need to come back and admit. Severe abdominal pain, it could be gut ischemia. Cold and clammy extremities, they could be in shock. Lethargy, irritability, restlessness, that is, these are manifestations of shock. Reduction in the intravascular compartment, right? Lethargy, irritability, restlessness. Bleeding tendency, including intermenstrual bleeding or menorrhagia. Even if they are not in their period of menses, they can still have period. They can still have their PV bleeding. If that happens also, that can be a sign of DHF. Not passing urine for 6 hours, that is also very important. One thing, it could be due to poor oral intake because they are not tolerating. One thing is because even though they are taking oral, they are leaking too much that their renal perfusion is so less, right? Their renal perfusion is so less. So if the patient has these things, if the patient has these things, you definitely tell them to admit immediately, not to wait until the next day, right? Not to wait until the next day. So this is how you manage dengue fever, a febrile phase at home. Now let's see the next case. This is a 21-year-old girl coming with fever today, day 4. So day 4 of fever. Fever free since yesterday night. So more than 12 hours, the patient is fever free. She had vomited couple of times. Could be a sign of gut ischemia. WBCs are 2800. It has dropped. Hematocrit is 42. Okay. So now hematocrit, we need to know what is the baseline. That is why it is important that during febrile phase, we tell the patient to get a full blood count so that we know what is their baseline. Let's say their baseline is 35. So what is a 10% rise of hematocrit? Is a rise of 3.5. Let's say now the hematocrit is 42. From 35, how much has increased? 5, 6, 7. Almost 7 has increased, right? So if 7 has increased, that means 3.5 plus 3.5 means this is actually a 20% rise. So a 20% rise in hematocrit means the patient is definitely leaking. But if you look at a full blood count in a superficial glance, if you look at a if you look at a full blood count in a very superficial glance, you would not notice, right, okay, the hematocrit is increased from 35 to 42. I mean, okay, fine. I mean, you won't notice that this is abnormal unless you calculate what is 10% of hematocrit of that patient. For that, you need the baseline. Let's say the patient comes to you during critical phase, during severe dehydration. Their first uh, hematocrit will be high. Then what do? You actually hydrate them. You hydrate them and repeat the PCV. You hydrate them and repeat the PCV. Then you will see that their PCV going back to their baseline. So this patient having a PCV of 42. We don't know if this PCV is her baseline or not. We don't know. Platelets are less than 130,000. CRP is less than 5, so you don't have to worry about a bacterial infection. CRFT is less than 2, somewhat reassuring. That means the vital organs perfusion is somewhat okay because CRFT is less than 2. Blood pressure is 110 by 80. Calculate the pulse pressure. What is the pulse pressure? 80, 90, 100, 110. So pulse pressure is 30. If the pulse pressure is narrow, if the pulse pressure is less than 20, if the pulse pressure is narrow, now that is a problem. Right? But here the pulse pressure is not narrow. Yes, she is having a tachycardia. So what can you conclude in this scenario? So how would you manage? So this is a patient who is on day 4 coming with 12 hours of fever free. She has some symptoms of gut ischemia which suggests leaking, but we don't know the baseline hematocrit. But so far, the organ perfusion seems okay because the pulse pressure is okay and CRFT is okay. So basically, this is actually a DHF. This is actually DHF, right? So in the ward, you need to quickly start red chart, right? You need to quickly start red chart. I'll show you a red chart. Once again, the chart which I'm having is not red because it is printed in red ink. I have it in black, but imagine that it is red, right? So red chart is basically vitals are monitored hourly. Hematocrit is monitored 3 hourly. Urine output is monitored 3 hourly. So what is the basis of red chart? The basis of red chart is actually detect the patient going into shock. Now, the basis of blue chart is you are detecting the patient going into leak. In red chart, you are detecting the patient going into shock. That is why you monitor hourly, right? Right. So during DHF, the most important things, fluid prescription. So basically you need to calculate something called the fluid quota. It is actually the amount of fluid which has to be given during the 48 hours. It is actually maintenance plus 5% deficit. Maintenance plus 5% deficit. Maintenance plus 5% deficit. I'll teach you how to calculate and we'll have some practice examples, right? So this is the most important thing. The next is keep monitoring hourly so that you detect them going into shock if at all they do go into shock, right? Monitor. Next, suspect bleeding whenever necessary. Now, what do you mean whenever necessary? Let's say the patient is going into shock, but you are giving fluids, still the shock is not improving. Then you need to think that there might be something else going on. There might be some bleeding. In a man, this could be this could be a upper GI bleeding, but melena you will see after 24 to 48 hours. So when that happens, that is too late. But suspect bleeding, so you look from your serial hematocrit monitoring, because you keep monitoring hematocrit 3 hourly. When you monitor hematocrit 3 hourly, you can either see is there a hemoconcentration or is there a drop in the hemoconcentration. So when there's bleeding, the hematocrit will drop despite clinical worsening. Hematocrit will drop despite clinical worsening. If the hematocrit is dropping with clinical improvement, you are happy, but the patient is getting bad and still the hematocrit is dropping, you need to give blood transfusion. At that time, when you do a full blood count and check the hemoglobin might be normal, because a drop in hemoglobin will take around 1 or 2 days. But hematocrit is a very sensitive marker where even if the hemoglobin is normal, you transfuse blood, right? These are the main things what we have to make sure that we do in a DHF. Now, how to detect critical phase? Now, that is an important skill. Okay. Now, this is the skill what HOs should have, because you all will be the people who will be in the ward during the night. Now, let's say you are doing the night rounds at 8 p.m. and you miss this patient who is in critical phase. Next, you will come at 6:30 a.m. and see. Just imagine how many hours. 8, 9, 10, 11, 12. So almost 10 hours. So 10 hours this patient has been in compensated shock. And then now in the morning when you're seeing, he has already been in shock for 10 hours. You do a blood gas and you see the lactates. Lactates are 17. Already you miss the bus. The patient will immediately go into decompensated shock and quickly progress into death. Now, the funny part of dengue is, now, when a patient is having septic shock, cardiogenic shock, anaphylactic shock, the patient is very ill. The patient is on bed, patient can't even move an inch, patient can't talk. By looking at the patient itself, oh my God, this patient is not doing good. But that does not happen in dengue. The patient will be eating, talking, smiling during compensated shock. Compensated shock is only detected by monitoring. That is why they emphasize a lot in this guideline, and they train us to monitor, because that is how we detect compensated shock. Because the moment you miss compensated shock, the patient can be around 10 hours in compensated shock without anything. But the moment they go into decompensated shock, bam, they quickly progress into multi-organ failure and they die, and recovery is definitely a miracle. So how to detect critical phase? Now let's say I'll just give you some examples of a full blood count, right? So you have the WBC, the neutrophil lymphocyte ratio, you have the hematocrit, and you have the platelets. Let's say this is day 3 morning. The patient comes with a count of 4,800, neutrophils 70, lymphocytes 30, hematocrit. Let's say the baseline was around 35, platelets 152. So now what do? You tell the patient, you give advices to repeat full blood count again next day morning and count. Now the count is like this: 2.8, 52%, 48%. Hematocrit, let's say, is now uh, 38. Platelets are dropping to 122. Now day 4. Now day 4 he's fever free, right? Day 4 he's fever free, but he's completely fine, no other complaints. Now day 4 night, he's very enthusiastic, he's very self-concerned. So he has a RCD lab right in front of his house. So he quickly goes and he repeats a full blood count in the night. So the count is 2.6. Neutrophil ratio is now 48. This one is 52. And hematocrit is now on the rise. And platelets are, let's say, 79. Okay. So now do you see something different? Do you see something happening? You see that gradually the neutrophil lymphocyte ratio is becoming reversed. Neutrophil lymphocyte ratios are becoming reversed. There is a gradual rise in hematocrit. Now compared to day 3, in day 4 hematocrit has risen how much? 35 to 39. So 5, 6, 7, 8, 9. It has risen 4. So there is more than 10% rise of hematocrit. There's more than 10% rise of hematocrit. What about here? Platelets are continuous to drop. But you see from 152 to 122. But now from 122 to 79, there is a abrupt drop. Okay, so this is how you detect leaking biochemically. Reversal of neutrophil lymphocyte ratio, the rise of hematocrit, the starting of rise of hematocrit, the abrupt drop of platelets, not just drop, abrupt drop of platelets. Now that is when your leak will start. That is when your leak has started. So in this patient, where do you think the leak has started? Here or here? It's here. So this is where the leak has started. So thank God he had a RC lab near his house that he did a full blood count at night. Just imagine he went on to day 5, he would be in grave trouble. So he has leaked somewhere midday, day 4. So this is how you see leaking in full blood count. So always when the patient is in your ward with all the full blood counts on the BHD, no, you can't compare by turning pages here and there. So always draw a table like this. Draw a table like this and tabulate. Then you can compare when is the neutrophil lymphocyte reversal, when is the rise of hematocrit, when is the abrupt drop of platelets. Okay, now this is where when the patient leaks, and that is when you start red chart. Let's say he had these full blood counts with him at home he's like, nah, I don't have to go now. Let me go tomorrow morning, and day 5 morning he comes to you. But he comes to you with all these full blood counts, right? So now in the ward, you have to start your critical chart. But in your critical chart, I'll show you the chart. There is a place where you mention what is the time you start at the critical phase monitoring. What is the time you start at the critical phase monitoring? Now, that should be this time. Midday, either take the day 4 at 12 noon. Therefore, 12 noon should be the start of your critical phase. That should be mentioned. And by the time the patient has admitted here, you need to skip that amount of time and start from this time of onwards from ward. So this is the practice what you have to get in dengue critical phase chart monitoring, because this chart does not only belong to the nurses, doctors also should be actively involved in this chart, especially the house officers, right? So you need to know what is the basis, what is the idea of this chart. So basically this is what, so when to start critical phase is very important, right? So this is what do you, this is how you detect critical phase. Now, how to prescribe fluids in DHF? I told you that M plus 5%. So maintenance with 5% deficit. So how do you calculate it? The maintenance is calculated like this. The first 10 kgs 100 ml per kg, second 10 kgs 50 ml per kg. From there onwards until maximum of 50 kg, for each kg you take 20 ml. Let's say a patient comes with 120 kgs. You don't calculate fluids for 120 kg. The maximum you calculate is 50. Let's say the patient is 42 kg. Okay, so I'm not that good in maths. Okay, like, okay, let's calculate together. So 42. So first 10. Then what? The second 10. 10 into, sorry, 10 into 100 and 10. See, I told you I'm not that good in maths. So then 42 means you have another 22 kilos, right? So into 20. So this is your maintenance plus 5% deficit is 50 mLs per kg. So 50 into 42, right? So this is 1000, this is 500. So so how do you do this? So 22, 220, 440, right? So 1500, 1900, 1940. Just correct me if I'm wrong. I'm just, I hate calculating stuff. I addicted to the calculator. Right. So how do you do this? So 42 into 10 is 420. That into 5 is 0, 5 2s are 10, 5 4s are 20, 21. Right? So 2100. Right. So 0 0 0 4 9 10 2 3 4. Okay. So 4040 mLs should be given in a period of 48 hours. Now, if it is 50 kilos, remember it is 4600 ml over 48 hours. Now, this 4040 ml is the total fluid quota which you will have to give throughout the critical phase. So, you need to make sure, you have to decide how much to give, what rate you should give, and you need to detect, is this the peak of his leak? If this is the peak of his leak, you need to give the maximum amount of fluids during that time, and you need to always match the leak with the amount of fluid given and try not to exceed. Try not to exceed. If the patient comes from home and gets admitted in the mid of the critical phase, don't worry. You can give good amount of fluids, because most of the time at home they are dehydrated. Unless he's a well-educated person who really knows what he or she is doing and have been taking 100 cc per hour at home, then you can take that into consideration if she's reliable. If she's not reliable, you have no clue what she has taken, you can give a good amount of fluids like the 4040, whatever the periods remaining, right? So early detection of shock, now that is what you need to do in DHF. You monitor hourly so that you detect shock. Now in a patient, right, what is compensated shock, what is decompensated shock, what is profound shock? Compensated shock is defined when the circulatory failure, when there is a circulatory failure because there is a narrow pulse pressure, the pulse pressure is less or equal to 20, that is a compensated shock, right? So the patient might be having a pressure of 110 by 90. No, 110 by 90, when you look at a glance, the patient has a blood pressure, okay, blood pressure. But come on, look at the pulse pressure. The pulse pressure is 20. So technically, this is compensated shock. And if you don't pay attention, you will miss, right? You will miss. So compensated shock, very important. That is the most common thing we miss because we don't pay attention. Next, if there is a hypotension, like systolic blood pressure either less than 90 or there is a reduction in systolic blood pressure more than 20%. Now, why they have mentioned this? Because some people can have their normal blood pressures with a systolic blood pressure of 90. So that 90 does not count as decompensated shock, right? That 90 does not count as decompensated shock. What we do is we calculate 20% of this. So 10% is 9, 10% is 9. So 20% is 18. So a drop of 18 millimeter mercury from 90 is considered as a decompensated shock. A decompensated shock in a patient whose baseline blood pressure is 90 systolic, right? Now, profound shock is when you can't record a blood pressure and you can't even feel a pulse. You can't record a blood pressure. Now, compensated shock, the patient can go on for hours. But decompensated and profound, if you find a patient, you have to pray very hard. They will definitely go into organ dysfunction and they will die soon. They will die right in front of you. They'll deteriorate and you won't be able to do anything. And finally, dengue is one of the things where even a house officer is called and held uh, um, questionable, held to answer in a dengue mortality review. And trust me, mortality review goes very harsh. Even for a consultant, he won't be able to answer at times, and they are very harsh on mortality review. So, if you have a dengue leaker in your ward, that is the most important patient in your ward. Most important patient, right? Right. So, symptoms of shock or symptoms that patients are going to shock. They might be complaining of sweating, abdominal pain, persistent vomiting, restlessness, altered consciousness, postural dizziness, reduced urine output, right? So another important thing now, when you are calculating the urine output, let's say the patient's weight is 100 kg. Now you calculated the fluids for 50 kg, let's say the patient passed around 100 ml of urine. You don't divide it by his body weight. Instead, you divide it by the kilos you use to calculate the fluids. Okay. If you use 50 kgs for fluids, for urine output also, you need to divide by 50, even though his weight is 100. So just remember that. So when you're examining the patient, if the patient has cold and clammy extremities, capillary refilling time prolonged, unexplained tachycardia, increasing diastolic pressure, right? Narrowing pulse pressure, postural drop of more than 20, hypotension, especially reduction of systolic blood pressure 20% from baseline, and then the patient is becoming tachypneic. Now, these are signs that patient is in shock. Now, you have the systolic blood pressure and the diastolic blood pressure. Now, you know that the systolic blood pressure is when there is the rapid ejection phase. The pressure maintained in the aorta during the ventricular systole is your systolic blood pressure. Now, the pressure maintained in your aorta during the ventricular diastole is your diastolic blood pressure. So, the diastolic blood pressure is usually maintained by the recoil of the aorta. Now, what happens is when there is a significant leak and the patient is going into shock, what happens is that there is an intravascular compartment reduction. Now, there is an intravascular compartment reduction. So, your pressure will start to drop. Your systolic pressure will start to drop. Now, what happens is that before your systolic pressure starts to drop, as a compensation, your aorta, your blood pressure, your vessels will try to constrict to increase your total peripheral resistance. So, the first thing what will happen is your diastolic pressure will increase. When your diastolic pressure increases, that is when your pulse pressure becomes narrow. That is when your pulse pressure becomes narrow. First, the first sign of shock is diastolic pressure will increase, narrowing the pulse pressure. Then later only you go into decompensated shock where your systolic blood pressure falls. Once the systolic blood pressure falls, it is a roller coaster ride downhill, rapid progression of events to leading into multi-organ dysfunction syndrome and death. All right. So how to monitor a patient with DHF? Now I told you patient with DHF should be on a red chart. Red chart, what are the things you monitor? The vitals are monitored hourly. Hematocrit is monitored 3 hourly. Urine output is monitored 3 hourly. Full blood count is monitored 12 hourly, twice a day. Remember, in febrile phase, once a day is enough. In DHF, in critical phase, you need to take full blood counts twice a day, right? So these are the main things what you have to do and make sure the adequate fluids are going on, right? So this is the chart. Okay, so this is the chart. This is called the red chart. Now the thing is, I have this in black, but I I have this in black, but in your words this will be printed in red, right? So that is why we call this a red chart. Now, what are the important things you find in a red chart? Now, the important things you find in a red chart is name is not important, right? BHT number is important because they can have similar names. So to confuse, the BHT number is important. Next, what is the most important thing? The weight, say 40 kgs. The weight is very important. The weight is very important. Next is you calculate the M plus 5. You calculate the fluid quota and write. Let's say she's 50 kgs. So you need to write, okay, this is 4600 ml. So 4600 ml. Right. So let's see what is there in this chart. So this chart, listen guys, this chart is very important because there are so many things where you can use it as a tool, as an adjunct to find out if the patient is going into shock or not, right? So just see this whole length. If you count, there are 24 small boxes. See, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24. So there are 24. That indicates starting from the 0 hour to 24 hours. So this chart has two sides. This is for the first side and the other side. So the first side is the first 24 hours. The other side is the next 24 hours, right? So this is the start of the critical phase. This is the 24th hour of the critical phase. Then you turn the chart the other side. Then it starts again from this side now. So you start from the 25th hour. Then you go on to 48th hour. So if you take this chart, where would you expect the most complications to occur? Where would you expect the most complications to occur? Where would you expect the patient to go into leak, or sorry, I mean shock? It is the peak, right? Because the leak follows a normal distribution, and the maximum leak happens in 24 hours. So this period, and let's say there is other chart is also here. So this period in your chart is very important. When the patient is coming towards this period, you need to anticipate that this patient might go into shock. This patient might go into shock. We need to monitor sincerely, right? Because this is the period where they might go into shock, right? Here, if patient goes into shock, two things. One thing, the timing might be wrong. One thing, you might not be giving enough fluids, right? So what is here? Commencement of critical phase means, when do you start? When is the 0th hour? Let's say 8 a.m. of 23rd May 2023, right? So from here, it will be 8 a.m. Then this will become 9, 10, 11, 12, 1, 2, 3, 4, 5, so onwards. Now here is your fluids. So for oral, no, they have given a color codes. Like you will see in your charts in your ward that oral is actually dots. Saline is across this way. Dextran is actually crisscross. Okay, the legend is different here, but this is what you see in your word. It will be dots for oral, uh, dashed lines for saline, and crisscrossed lines for dextran. So how do you mark? Let's say from 8 to 9, you have given 100 cc IV. So 100 cc IV. So this is how you mark it, 100 cc IV. So during this, you need to document the hematocrit, you need to document the CRFT, you need to document the pulse rate, the blood pressure, the pulse pressure, the respiratory rate, and whatever the current platelet count, whatever the current WBC, and then the urine output. Mind it that the urine output, you need to convert it into milliliter per kg per hour. So that is easy. So what is the target? 0.5. 0.5 ml per kg per hour. If the urine output is less than that, that means there's a problem. Okay. So just imagine, by just looking at this chart, you know what fluid is given, you know what time of the critical phase it is, you know what are the parameters, you know what is the platelet, what is the trend going on. So hematocrit should be measured every 3 hours, So first hour, second hour, third hour, then again hematocrit will be here. Then 1, 2, 3 here. 1, 2, 3 here. So every third hour, the hematocrit should be documented, right? Every hour the vitals should be documented. So okay, so let's just imagine that the pulse rate here has been 70, 76, 80, 80, 80, 84, then 90, 96, 110, 120. Now you see here, now when you're looking at the chart, okay, you know that something is wrong somewhere here. Like from until 90 it's considered okay now, but when going to 100, there's something wrong. So what has happened here? So what has happened to the hematocrit? What has happened to the blood pressure? What has happened to the urine output? So everything you can see it from this chart. So you know what went wrong, where the gauge has gone wrong, right? So let's say the urine output starts to reduce. What you can do is you can slightly increase the fluids. Let's say now you give 150 cc per hour. you can give 150 cc per hour for few hours. Let's say now during this period, you detected the patient going into shock. I'll teach you how to manage shock. But now let's say the patient goes into shock. When the patient goes into shock, the way how to treat shock is actually a 10 ml per kg per hour bolus. 10 ml per kg per hour bolus. Let's say the patient is 50 kilos, so the 10 ml is 500. No? So whenever the patient goes into shock, the monitoring should be quarter hourly. Now red chart is monitored hourly, no? So every box is taken as 1 hour. So when the patient goes into shock, every box should be taken as 15 minutes. So let's say the patient goes into shock at around 11. So 1, 2, 3, 4. Now this should be 12, right? These 4 boxes make 1 hour. So let's say what is 500, 500, right? So here it is. And then number 12 is also here. So how do you mark? Do you color the whole thing? I mean, that will be misleading because see here, uh, one column, one column, one column. So here, just imagine for 1 hour, there will be 4 columns. It will be misleading. So you mark it instead like this. So you have given say line 500 over 1 hour, just one column. So you know that the patient has been in shock, that they've used 4 boxes in 1 hour. That means now this period the patient is in shock, right? That is why there is a monitoring like this. That is why there's a documentation like that. So they have given a bolus. But if you draw, like if you color 4 columns, at a glance, you would be like, oh my God, how many boluses have been given? 1, 2, 3, 4. Have they given 4 boluses? So no, they have given only one bolus. Now let's say after this, the patient recovered from shock. You don't then definitely, you don't go back to, okay, all right, now the shock is improved. Now let's continue 100 cc per hour. You don't do that. Now this is 10 ml per kg hour, per hour. Then what do? You reduce it to 7.5 ml per kg per hour. Continue it for like around 1 or 2 hours. Then you go for 5 ml per kg per hour. Continue it for few hours. Then you go for 3 ml per kg per hour. Continue for few hours. Then finally you go into the maintenance phase. So basically the recovery should be somewhat like this. So let's say 1, 2, 3, 4 for 4 hours. So now the patient is out of shock. So you don't have to monitor hourly. So again, sorry, you don't have to monitor every 15 minutes. So now the patient is back. So 1 hour, 2 hour, 3 hour, 4 hours. 4 hours you have given this amount of fluids. Then now you have given another 3 hours of this fluid like this. Then finally you come another 3 hours. And finally is basic. So this is how you come down with fluids. You don't rapidly come down, because if you rapidly come down with your fluids, the patient goes into rebound shock. The patient can go into rebound shock. So you should go in a stepwise manner, right? So just take a note of this. So this is how you mark the chart, and this is the chart, and you need to be aware that this period is the period where the patient might go into shock. So you need to be cautious, right? So right. So I'm sure you all understand, and as HOs, you all should be well versed with this, because this is how you detect patients. Let's go to the next case. Now there is a 21-year-old girl being treated for DHF in your ward, noted to have reduced urine output for the last 3 hours. Only 20 ml. Just imagine, this girl is having a urine output of only 20 cc for 3 hours. So that's very, very less, very small. Her blood pressures were 100 by 86. Now, what is the pulse pressure here? Less than 20. Tachycardic, reduced urine output, ill looking. Now, what is the diagnosis? This is a compensated shock. In a compensated shock, number one, do not forget PCV stat. Take blood for urgent PCV. While you send the blood to PCV, while they are putting it in the machine, then start 10 ml per kg over 1 hour bolus. 10 ml per kg over 1 hour bolus. Now that is how you manage shock, right? I'll teach you how to manage shock with the algorithm given in the thing. Before that, I want to teach you certain aspects. Now you have crystalloids, you have colloids, you have blood. No, out of this we are talking about dextran. So out of this, you need to know that, let's say the patient's baseline PCVs, patient's PCV is 40. Now patient is in shock. You're giving a bolus. So a bolus of crystalloid. Nicely remember this. A bolus of crystalloid will drop the PCV around 3 to 5. A bolus of crystalloids would drop the PCV around 40. Now, this is the normal drop, what we expect. Now, that is why I told you, when a patient is in shock, the first thing you do is measure PCV. And then you give the bolus. Soon after the bolus is over, measure the PCV again and see that have you met this target. Because when you give a crystalloid, it should drop 3 to 5. Let's say it did not drop. That means there is a much severe leak that you need to give another bolus. Okay? There is a much severe leak that you need to give another bolus. That is what it means. Let's say it dropped more than 5. Like from 40, it dropped to like around 32. Now, obviously the drop is not due to a bolus, because bolus will drop it only 3 to 5. Together with leaking, there is a bleeding going on. So although you are giving fluids now, that will drop the PCV, there is an ongoing bleeding which is further dropping the PCV. So if the PCV drop is beyond the normal drop of that particular liquid, you need to suspect bleeding. You need to suspect bleeding, and this is the most important point which you have to understand. What about dextran? Let's say the PCV is 40. You are giving a bolus of dextran. When you give a bolus of dextran, the expected drop is around 8 to 10. So from 40 to around maximum 32 or 30. Now that is the normal drop. If the drop is more severe, like okay, from 40, it has dropped to 29. Okay, now you are in soup, because the patient might be bleeding. I mean, not might be, patient is bleeding, because the drop is more than the normal drop of that particular liquid. Now blood, always we need to give blood 5 ml per kg. 5 ml per kg, that is the dose. So let's say the patient is 50 kgs. So 250 ml of blood, that is how you should give. Now when you give a pack of blood, we are expecting the PCV to rise. No, the rise in PCV is around 3 to 5. The rise in PCV is around 3 to 5. Let's say the PCV was 35. You give blood, the PCV can rise up to maximum 40. If the PCV is rising more than 40, there is a additional leaking going on. That leaking is causing hemoconcentration and rising the PCV, right? So that's why PCV is such an important thing. It is done in the ward in a small machine, but it gives you so much details that you can identify whether the patient needs blood or colloid or crystalloid, right? So PCV is very, very important. Now look at this diagram. This diagram is in your dengue guideline. So you have shock with narrow pulse pressure. This is the algorithm how to manage compensated shock. This is how to manage decompensated or profound shock. Let's see how to manage shock with compensated shock. The moment you see a narrow pulse pressure, look at this. Number one, oxygen via face mask or a nasal cannula or a nasal catheter. So the first thing is connect the patient to oxygen. Okay, now you found the patient in shock, quickly connect oxygen, take blood for PCV. See, the next one is take blood for PCV. Then next is immediate volume replacement. How do you replace? 10 ml per kg over 1 hour. Then what do you do? Then you reassess. And see if the pulse pressure has improved. Has the pulse pressure become above 25? Let's say the pulse pressure has improved. Yes. Then what do? You don't go back to the basal fluid rate like I showed you before. You go back to 7.5 ml per kg per hour. You continue that for few hours. Then you drop to 3.5, sorry, 5.5 ml per kg per hour. Then you drop for 3 ml per kg per hour. Then you go into your basal rate depending on the urine output and the hematocrit. Let's say the patient did not recover. The pulse pressure is still narrow. The patient is still in shock. Then what do? Soon after that saline bolus, you repeat HCT. Let's say the HCT is still remaining high. Then what do? You can give the second bolus. You can give the second crystalloid bolus. That is also 10 ml per kg per hour over 1. Then what do? After that bolus is over, you assess again. And you check the HCT again. Now, if the hematocrit is still high, let's say the hematocrit is not at all dropping, that means there is a profound leak. Now, the problem now is you have given two boluses. After giving two boluses, the solution is to go for a colloid. So here what you is you give dextran. So how do you give dextran? 10 ml per kg over 1 hour. It's so easy. Everything is 10 ml per kg over 1 hour. So you don't give dextran any other way because the guideline says it's 10 ml per kg per hour. Nothing else. Meanwhile, while you are resuscitating, always check for ABCS. Acidosis, bleeding, calcium, sugar. Acidosis, bleeding, calcium, sugar. The patient might be acidotic. The patient might be bleeding. The patient might be hypocalcemic. The patient might be hypoglycemic. Until you correct them, you will not correct the shock. So while you are resuscitating, send blood for blood gas. Send blood for calcium. Check random blood sugars. Look for bleeding, right? Let's say after the colloid, the patient still doesn't improve. You can give maximum 3 boluses of colloid in 24 hours. Maximum is 1500 ml of colloid can be given in 1 hour. But most of the time, by the time you give 1 bolus of colloid, the patient will improve from shock. Once the patient improves from shock, what do? You continue the same thing what we did before. Go to 7.5 ml per kg per hour, then 5 ml per kg per hour, then 3 ml per kg per hour for few hours, and then you tail it off, right? Let's say whenever you are checking the hematocrit after giving a crystalloid bolus or a colloid bolus, the hematocrit is low. The hematocrit is low. What does that mean? That means this shock is due to bleeding. You need to give red cells. You need to give blood. Blood transfusion should be given. 5 ml per kg as a bolus should be given to solve the shock, right? So when the hematocrit is rising, think about leak. When the hematocrit is dropping, think about bleeding, right? Hemoglobin might be normal, guys. Hemoglobin might be normal, but you need to make sure that if the hematocrit is dropping, that's an indication for blood transfusion. Now, what is different from narrow pulse pressure to decompensated or profound shock? Here, first you have to do is a rapid bolus of 10 ml per kg. Now, what do you mean by rapid bolus and this? This is given 10 ml per kg over 1 hour. This is given as a rapid bolus. Rapid bolus is around 20 minutes or less. Within 20 minutes or less, you give the fluid. If the blood pressure is not recordable, like if the patient is in profound shock, you take the saline and squeeze the saline until it free flows inside the body, right? And the next, the whole thing is the same as this. The only difference is the first step: compensated shock, decompensated, and profound shock. If it is decompensated, you give it as a rapid bolus, which is less than 20 minutes. If it is profound shock, you give it as free flow. Ideally, you have to take the saline bottle and squeeze it, right? So, right, this is how you manage shock, and this is mentioned in the guideline, right? So, if you look at this 2-3 times and practice it, you will not forget it. But I want you to understand the concept, right? Okay, let's go for the other case. Now, while managing the 21-year-old girl as a compensated shock, her PCV, which was 40, dropped to 31 after one fluid bolus. Okay, so PCV 40 dropped to 31. So how much dropped? 9, drop of 9 after one fluid bolus. Now let's say one crystalloid bolus will drop the PCV 3 to 5, but here the drop is 9, more than 3 to 5. So what is your diagnosis? So what is it? See, the lactate levels are also high. Blood pressure also did not improve. So what does this mean? There is bleeding. There is bleeding. First look for bleeding. If you can't find it is occult bleeding, immediately transfuse. Transfuse blood. How do you transfuse blood? 5 ml per kg. 5 ml per kg packed red cells is given as a bolus. Okay. So indications for blood transfusion: hematocrit not high as expected for the degree of shock to be explained by plasma leakage alone. Like, let's say there is a shock. Now, if there is a leak, guys, listen to me carefully. If there is a leak, there should be a hemo concentration. So your HCT should be high. But the patient is in shock, but with normal hematocrit or even low hematocrit. Now that should, like, you should definitely think about bleeding here. So that is an indication for blood transfusion. Patient is in shock, but HCT is low. You need to transfuse. A drop in hematocrit without clinical improvement. I've told this before. A drop in hematocrit without clinical improvement. A drop in hematocrit with clinical improvement, you are happy, the patient is recovering. But drop with deterioration, there is bleeding. Hypotension not responding to fluid therapy. That means definitely there should be some component which is aiding for the shock, which is bleeding. Severe metabolic acidosis and end organ dysfunction despite adequate fluid replacement. You are giving enough of fluid, but still the patient is in shock. The lactates are high. There is metabolic acidosis, end organ dysfunction like oliguria, like liver dysfunction. That is due to bleeding. Bleeding causes depletion of intravascular compartment. So you need to give blood transfusion. So keep this in your head, that what are the indications in DHF where you need to give blood transfusion. Now, next important thing. Now, you might be in the medical ward. You might be in the gen ward, or you might be in the obs ward. A pregnant mother, a pregnant lady coming with DHF, who is responsible for managing this? Is it the gynecology team, obstetrician team? No, it is the medical team. The medical team is responsible to treat patients with DHF. The moment a pregnant lady comes with DHF, the responsibility is the medical teams. So the patient might be in the obstetric ward because you have the CTG facilities there, and it's difficult to do fetal well-being monitoring in a medical ward. But although the patient is in the GynObs ward, the patient should be looked after by the medical team. Now, there are indications for delivery. Now, during critical phase, during dengue, let's say the mother had a wish to deliver the baby on the 26th of May. The mother had a wish to deliver the baby on the 26th of May. Now, let's say on the 25th, she came into DHF. Now, when is she finishing DHF? 48 hours now. So 25, 26, 27. So 27th. But mother insists, no, I want to deliver on the 26th. That is one scenario. Let's say another scenario. Patient develops DHF on the 25th, but on the 26th, the patient develops, let's say, fetal bradycardia, something like that. Yeah, the baby has to be delivered, or let's say a PPROM, baby has to be delivered. Do we allow the obstetrics team to deliver? We somehow manage to keep the pregnancy viable until the end of critical phase to deliver. We don't open up during critical phase. That is very, very detrimental, because you will open, you will take the baby, finally the mother will die. So in this case, the utmost importance goes to the mother. Utmost. If the mother's life is in danger, if the mother's life is in danger that they have to be delivered, that is the only case where we allow delivery. If not, no matter what, we don't consider the child here. We consider the mother. Mother is the utmost priority. Unless the mother's life is in danger, we don't promote delivery. Even if the patient is having a PPROM and contractions, we try to give tocolytics and keep the contractions at a minimum rate until they pass critical phase, right? If the patient is having if the mother is having a risk, then we allow delivery. To maintain a platelet count above 50,000 is needed to go for delivery. So if the platelet count is less than that, we immediately put the mother to the theater, immediately get down platelets, transfuse platelets 5 to 10 minutes before the procedure, quickly do the cesarean section, take the baby out and close the mother up and bring back to the ICU. But that happens in a very rare situation, only unless to save mother's life. Okay, that is the concept. I just want you to understand that concept. It's not that we are insensitive to the child, it's just that the mother is very important, because without the mother there won't be a child, and even if the child is born without the mother, the life would be difficult, right? So yes, mother is very important, so we don't compromise uh, mother's life. In a case of fetal compromise, we give the priority to the mother, not the fetus, right? So counseling family members in the initial stages of dengue is very important in a pregnancy situation. And who counsels this patient in the Sri Lankan setup? It is you guys. Unless you are working in a teaching hospital, the registrars will do the counseling part. If you are in a base hospital, you are the chief in the ward when the consultant is not around. So, what way ward doctor. So, you are the most popular person than the consultant if you become interns, right? So sometimes the patients might not realize the consultant, but they might see you in a supermarket and they might come near you in peripheries. It's very rare in cities, but in peripheries, it's like that. So yeah, counseling the family during dengue is very essential. So, okay, so after you have managed dengue successfully, now the patient is in recovery. How do you discharge? Now, there is a criteria for you to be discharged. No fever for at least 24 hours without the usage of antipyretic drugs. At least 24 hours should be there without fever. This I mean after the critical phase is over. After the critical phase is over. At least 2 days have lapsed after recovery from shock. If the patient was in shock, she needs to wait 2 days after the end of critical phase. Good general condition with improving appetite. Normal HCT at baseline value around 38 to 40 when baseline value is not known. No distress from pleural effusions or fluid overloads. No ascites. This is the both is talking about fluid overload. Platelet count has risen above 50,000. Now this is important it's a legal point that the platelets should rise above 50. Now the problem is now during the descending phase of the critical phase, the platelets can drop to 3,000. The platelet can drop to 3,000 or 2,000. Now the rise of this to 50,000 might take some time. Sometimes the bone marrow will release very immature platelets that the machine will not count them. The machine will count them as clumps. So the platelets count will still be low in a full blood count given by the machine. So always ask for a manual count. The manual count will give the actual number of platelets because the new platelets coming from the bone marrow are very big. So they are counted as clumps in the machine, right? No other complications of dengue, like no other organ dysfunctions like acute kidney injury, acute liver injury, so on and so forth. So if all these are fulfilling, you can safely discharge the patient. When discharging the patient, you need to advise the patient on not to have contact sports. Why am I saying this? There was a boy in our ward, 17-year-old boy. He's a rugby player from Trinity. So he was admitted with dengue. He had an uncomplicated DHF course where he leaked, but he did not go into shock. We managed nicely, and then finally we discharged him. When we are discharging him, the platelets was 18,000. So we told him, okay, just relax at home. Don't worry, this will increase in no time. He's an over enthusiastic sportsman, a rugby player. He has gone to play rugby, right? He has not rested, he has gone to play rugby. Then what has happened is after around 4 days, severe pain around his hip joint and lower abdomen and groin, where he can't even move his leg, he can't even flex his leg. He was admitted to the ETU, and through the ETU, he was sent to the surgical casualty. Very tender to palpate, and he was in a flexed position, and finally he went to ultrasound scan. Ultrasound scan showed psoas hematoma. So they immediately went into surgery. They drained around 3.5 liters of blood. There was 3.5 liters. You basically have 5 liters in your body. 3.5 liters had been in your psoas muscle. That area is quite voluminous, that it can hold quite a huge volume. So That is because, and then when they have checked the full blood count, the platelet count was 120,000. Now platelet count is okay. Now why was he bleeding? That is because I told you that there is a thrombasthenia. This thrombasthenia, the platelets, although they are immature platelets and they are dysfunctional and they take time to get their normal functionality. So that is why even single antiplatelets, dual antiplatelets, we start after around 4 or 5 days. We wait for 4 or 5 days until the platelets get their functions back. Until the platelets get their function back. So these are the things what you have to advise them on discharge, that definitely rest is necessary. It doesn't mean that they have to be confined to the bed. It's just that they should not be having contact sports. Let's go for the next case. There is a 17-year-old girl who is 40 kgs heavy. She gets admitted and diagnosed with DHF. She was treated with IV fluids as she was not tolerating oral liquids. Now, 3900 ml is her fluid quota for 48 hours. However, after 32 hours, fluids had been given to her at a flat rate of 100 ml per hour. Right. So, 32 to 48 is how many hours? 32 to 42 is 10. 42 to 48 is 16. So, 16 hours at a rate of 100 ml per hour. So it is 1600. So until 48 hours, 1600 ml was given from the 32nd hour. Now what has happened? Now, what it means is until 32 hours, 100 cc had been given. So 32 into 100. So 3200. Now, by the time he is reaching 32 hours, 3200 cc had been given. The quota is 3900. So what is remaining? Only 700 ml. So only 700 ml to be given over 16 hours. So now what happens is urine output starts to drop and hematocrit starts to rise above 30%. Now, what is above 30%? It is compensated shock. It is compensated shock. Now, what happens? Her pulse pressure is now less than 20. Compensated shock. How would you manage this patient? Right. So, this is a compensated shock in a patient who has already given too much of fluids. This is compensated shock in a patient who has been already given too much of fluids. Now, if you give another bolus of fluids, what will happen? Just imagine in recovery, when all the fluid comes back, the patient will go into fluid overload, pulmonary edema, heart failure, death. Now here, although you have to follow the guideline, you have to skip certain steps and directly go into colloid. So colloid is the option here. Now what does this colloid do? Now I told you that you have to give colloids as a 10 ml per kg over 1 hour. Now why do you give this? You don't give it just by hanging the colloid saline right next to the patient. You have to give it through an infusion pump. Now why do you have to give it through an infusion pump? Is that this colloid is made up of large small molecules. So this is how the colloid is made. Now when you give it in an infusion pump, all these multiple sized molecules will get inside the blood vessel at once. But when you give it in a variable rate, what happens is first the small molecules will come, then the large molecules will come. No, they will be coming inside the blood vessel in a very haphazard way. Now what happens is when all of this is there at once in your blood vessel, they create a very stable structure which will draw water from outside to inside. It will draw water from outside to inside. Now that is why we give colloid, because colloids are volume expanders. They are volume expanders. You give it to the intravascular space, the fluid comes in to the blood vessel, right? So that is why you use colloids in a patient whom you can't give more fluids, because they will also leak out. So what we do is we give colloids and try to expand the intravascular volume by using the fluid which has already extravasated outside, right? Now, what happens if you give it in a variable rate? That these small molecules will enter haphazardly, and these small molecules are so small that they can easily pass through the vascular penetrations during critical phase. So what happens? These molecules will go out to the extravascular space. Now, what is the point? Nothing remains in your blood. You are giving colloid to make sure that it remains in the blood vessel, but when you're giving it in a variable rate, they end up going out to the extravascular space. Now, the problem is that during recovery, all the fenestrations close. But water is permeable that it can come in. There is a reabsorption. But colloids cannot come. The moment the things are closed after recovery, the colloids remain outside in the extravascular spaces, like in the pleural space, peritoneal space. They remain. When they remain, what happens? They are really good culture medium for microorganisms. So then they develop complications like empyema, pus in your pleural cavity, high spiking fevers. They develop pleural effusions with empyema, and finally you have to send the patient to the thoracic unit for a chest tube, and sometimes video assisted thoracoscopy and pleural drainage procedures. And why unnecessary? This is all just a matter of giving dextran in an infusion pump. Just because you are lazy to get the infusion pump from the store and fixing it here, you are compromising the patient's quality of life. So always make sure when you're giving colloids, the nurses might put it just, they will just, doctor මට දන්නවා මේ 10 ml per kg පාවනේ මම මේ rate එක set කරලා දෙන්නම් කියලා. No, don't allow that. Always make them get the infusion pump, connect the dextrose via the infusion pump at that fixed rate. That is how you should give. So in this patient, you give colloid. So 10 ml per kg per hour of colloid you give, and then reassess PCV, and then finally you will see that the patient is coming out of shock, so that you are giving minimal amount of crystalloid so that the patient does not go into fluid overload. So regarding giving dextran, so the preferred colloid in DHF is dextran. It produces plasma volume expansion. It has got molecules of various sizes, which makes it possible. And to achieve this, which makes it, what does it mean is like the molecule has various sizes, that it gives the possibility for it to make a conglomerate structure that holds all the water inside. So it is a volume expander. That is why we need to achieve this. We need to give the patient it as a bolus, not as a slow infusion just by a saline. It's given as 500 ml over 1 hour or 250 ml over 30 minutes, both the same. Maximum dose is 1500 ml over 24 hours. Maximum dose is you can give dextran 3 times in 24 hours. Never use dextran in the early phase of leaking, and especially without correcting dehydration in a patient with high HCT. So normally when the hematocrit is very high, we have a tendency to think, no, okay, so there is a huge leaking. Let's give some dextran so that it will reabsorb some fluids into the vascular space. Now, without correcting dehydration, now dehydration per se can cause a rise in hematocrit. So in a dehydrated patient, there is no fluid in the extravascular space. So you giving colloids will not do any good. So never give colloids without correcting dehydration. Once you have given the enough amount of fluids, then you give dextran. Always make sure dextran is given towards the end, towards the latter period of your critical phase, not during the early period. The dextran should be given in the latter period of the phase, so that you make sure that enough of fluid has been given, and then now the next option is colloids. That is how you should give dextran, not the other way around. So dextran reduces hematocrit by 8 to 10. Normal saline will reduce it 4 to 5. Packed red cells, blood will increase it by 5. This I told you. So these are the basics what you need to know in relation to giving dextran. Now we are coming towards the end of this session. Just a little bit more words on prolonged shock. Prolonged shock. Now I told you why, yeah, in your internship you will be doing a night ward round. Now, why this night ward round is this important? Because that is the time where you detect who are the important patients in the ward, who are the critical patients in the, because until next day morning, you are called only if something happens, only if shit hits the ceiling, that is when you come to the ward. Until that, you will be in your quarters room. So when you're doing your night ward rounds, you need to detect things, you need to pick things up. If you miss it during your night ward round, that patient will have to wait until you come the next morning. Remember, dengue compensated shock patients are completely fine. You wouldn't even imagine in your weirdest dreams that this patient is in shock after looking at a compensated shock. They will be fine, eating, talking over the phone, WhatsApping their girlfriend. I mean, they'll be completely fine. Most of the time, we transfer compensated shock dengue to the ICU on a wheelchair. Can you imagine that? Normally, patients go to the ICU either intubated, unconscious, or on a stretcher. But here they go on a wheelchair because they are completely fine. But the thing is, compensated shock can easily progress into decompensated and profound shock. And once it goes to that, then there is no coming back. So, according to statistics, if you leave prolonged shock 10 hours untreated, death is inevitable. If you leave prolonged shock 10 hours untreated, death is inevitable. 4 hours untreated, they might go into liver failure. Now, how do you find out liver failure? AST, ALT. Let's say this takes around. Let's say. Let's say this takes around 3 hours to come from the lab. Remember, guys, when there is an acute liver injury, the transaminases rise will come after 48 hours. Let's say the transaminases are now 5,000 odd, but you need to know that this is corresponding to 48 hours back. So the only way to find out that the liver is getting damaged is your lactates, because your lactates are catabolized and broken down by your liver. So there will be a exponential rise. Example, you do one blood gas, the lactates might be 2.8. The next blood gas, 8.4. Next blood gas, 22. So you see, the rise is exponential. Exponential rise in lactates is a sign that your liver is in failure, right? The transaminases and all will come towards the end, towards the 48 hours. Then the bus is gone. Well, when you see exponential lactates also, the bus is almost gone, but at least you can run and catch the bus. But the moment you see ASTLTs in thousands, forget about the bus, you won't even see the bus, right? If there is a liver failure and renal failure both, the prognosis is only 10%. If there is 3 organs failing, like your liver, kidney and heart myocarditis. Trust me, survival is a miracle. So that is why monitoring, monitoring, monitoring. Dengue is all about monitoring because almost all dengue patients can be prevented from dying by accurate, precise, sincere monitoring. Most of the time, when you see dengue review meetings, the biggest mistake is that they have missed the shock. They have missed where you have to give fluids. They have missed. Why? No proper monitoring, improper monitoring. So if you monitor well, no patient with dengue has to die, right? So this is your blue chart. It will be blue, trust me. It's just black in my screen. This is your red chart. Once again, that will be red in your ward. It's not red here, right? So final, let's talk about the last case. An overloaded engineer. So there was an engineer in our ward. 28-year-old male. He was transferred from the local hospital. He was treated for the DHF in the local hospital, but when things got very bad, they ended up transferring it to us. So he is now almost at the 47th hour of the critical phase monitoring. Already 5,200 ml had been given already. What is the problem here now? Let's say the maximum weight we take is 50 kgs now. So the maximum amount of fluid we give in 48 hours is 4,600. Now he's not even completed 48 hours. In the 47th hour, now he has been given already 5,200 ml, right? Now you notice that he is short of breath and having reduced urine output and pronounced edema of the face and legs. Now what do you do? Now the problem here is that now he is recovering because he's almost towards the end of critical phase now. So towards the end of critical phase, what happens? There is leaking, there is resorption. So resorption is also there, leaking is also there, right? But it happens in a balance. So that is why towards the end, it is called the equilibrium phase. Equilibrium phase. Now, but what happens here is that gradually towards recovery, what happens is that the leaking will slowly reduce. The resorption will increase. Now, here what has happened? 5,200 ml has been given to this engineer that finally, when he is recovering, everything is starting to reabsorb. Now he is overloaded. Now he is fluid overloaded. So when fluid overloaded, what do you have to do? You have to make sure that you take out the fluids. But look at this question. Now he is having reduced urine output and pronounced edema of the face and legs. Why urine output is low? So we checked his blood pressures. He is in shock. Now, what does this mean? That means when this patient was actually in the peak of critical phase, when he needs the fluid the most, the fluid was not given. He was in intravascular compromise, but fluid was given in wrong timings. So that is why now during reabsorption also, he is in shock. But the problem is he's fluid overloaded. Now what? Now you can't even imagine giving crystalloids. So now the option is colloids, but there's a problem. Colloids will worsen pulmonary edema. Colloids will worsen the fluid overload. Why? It will reabsorb more and more fluids now. So what do? While you give dextran, you give Lasix. You give furosemide. This is not in the guideline, but this is how you manage in practical setup. So the patient is fluid overloaded. You have to give colloids. When you give colloids, what do? It will take the fluid from the extravascular space to the vascular space, because remember his intravascular compartment is depleted although he's fluid overloaded, but you can't afford all of that fluid to be in the intravascular compartment, so you need to make them go out. That is why you are giving furosemide. So you give colloids to get the fluid into the vascular space, then you give diuretics to push it out. So you want a polyuria so that you sort out this problem. So when the patient gets into this sort of a mess, the patient will go into a prolonged period of shock, guys. So this patient was managed in the ICU with colloid and Lasix, and additionally we give FFP infusions also, because FFP is much better than colloid in terms of volume expansion. So we give FFP infusion and Lasix infusion parallelly, try to maintain a urine output and his blood pressure while making sure he does not go into pulmonary edema. And he at one point he went into pulmonary edema, then we had to give some CPAP support. So that CPAP support helped him to come out of pulmonary edema. So he was in this period for more than 36 hours. So for more than 36 hours. So altogether 48 plus 36, uh, almost two whole 48 hours. We were extending the red chart and going on. Always remember, red chart is not confined only to 48 hours. Red chart is a chart which is defined to monitor dengue patients. If the patient is still in shock and extended shock, you can extend the red chart as how much ever you want. There is no legal thing about using red chart only for 48 hours. Most of the nurses will make a fuss. Now critical phase is over. ඇයි ඔයා මේ තාම රෙඩ් chart එක තියන් ඉන්නේ ડોක්ටර් මේ කොමිට් කරන්නකෝ අපි normal blue chart එක දාමු. No, you are the one to decide. If the patient is still in shock, if the patient is still in intravascular compromise, you can keep the chart as long as you want, right? There is no hard and fast rule. It benefits the patient because that is a, how do you say, it is something like a early warning score. The news chart, new early warning score, modified early warning score. It's like a warning score where you detect problems earlier with that chart. So after that, this patient finally recovered with these FFP transfusion and Lasix infusions. So this is the problem when you don't diagnose the critical phase at the correct time and you don't give the adequate amount of fluids when the person needs the fluid most. So that is all what you need to know about dengue as a house officer. And then if you know these concepts well, you can tackle any question in your ERPM paper. So trust me, they won't ask this depth in your ERPM papers. They will always ask simple ones, but I've gone one extra mile just to explain how things happen practically. Because whenever we get new house officers to our unit, uh, we do this orientation program for dengue for them before they start duties, because they need to know, because they are the ones who are dealing with the patients most of the time. So this is what we do. So any questions? You are free to ask any question. So I can answer that.
A question. During the red chart, so if you transfuse blood, does it count for the maintenance and the 5% deficit?
All right, that is a very good question you asked. I actually forgot to mention that. Right. Let's say you at this point you gave blood. Let's say you gave 250 cc. Now the patient is in shock, and you gave 250 cc over 1 hour. 1, 2, 3, 4. You gave blood. Now the thing is, you don't count blood into the fluid quota. You don't count blood into the fluid quota because you are replacing something that is lost. You are replacing something that is lost. So you don't count it in the fluid quota. So blood transfusions don't get counted into your M+5. So during this period, after the blood transfusion is over, you need to again start from the place where you stopped. If you had stopped here from 2300, from here you start from the 2300. So this period, you don't count this into your critical phase fluid cumulative. What else? What are the questions? And another thing, while the blood transfusion is going, do we connect another saline parallelly? No need. The blood transfusion alone is enough for that particular time. After that, you can connect the fluids. Can they drink during blood transfusion? Yes, they can. If they do drink, you need to calculate that and put it in the cumulative. Any burning questions? I take silence as there is no questions. You've understood it clear. So this is the basis of dengue. I'm sure it is not that complicated, but it takes some time for you to master the skill of detecting. So that is why you need to purposefully look for it. Unless until you purposefully look for it, you will never notice it. Right. If there are no further questions, we can wind up this session so that you can go revise. You have more 48 hours, right, for the exam. If there's no questions, we can wind it up. Are there any more questions? Okay, there's some chat box. Wait. All right. Okay. You're welcome. Thank you. So thank you, guys. I hope this session was productive because I myself had my personal experience that when I was doing ERPM, having dengue questions, clearing that was a big doubt. I mean, like I was not explained in this detail how to handle dengue patients. Like we just followed the tubes and that's how we studied. But once I came into practice, that is how we learned. So that is why I wanted to get this session. So thank you guys for joining. Wish you all the very best for those who are doing the exam this time. And let's wind up. Thanks for joining.